I have a zillion questions and suggestions. First of all, I thank Dr. Setkin from his presentation, which is an eye-opener, should be for the researchers, because the disease is in the whole peritoneum. Number two, we have to have it is very easy to say we should have this and that, but who is going to bear the expenses? Only those who have insurances and are rich, they can have all access to all these investigations and management. What about the poor people? Number three, there should be some genetic differences. What about the race? Somebody has to see globally in different countries what is the incidence and why there is less and why there is more in different parts of the world. I think the gene technology is very important, and development of screening tests very important, and there should be questions, all the time questions. Thank you for listening to me, and I need answers.
Thank you very much. Would somebody from the panel like to address the genetic comment about what we do in different countries? No, now it's off.
On? Okay. Okay. So one of the complexities about looking at international genetic data is that currently we still have very restricted source populations for genetic information and confirmed endometriosis information. So currently we have groups creating large consortia to have appropriately powered studies that include the United States, the United Kingdom, and Australia. We're also going to be collaborating with Dr. Duga's group from Belgium. And one of the complications is that the true incidence and prevalence of the disease is still elusive even within the countries with more advanced access to care. And so you're absolutely correct that looking at geographic variation, questioning if geographic variation that's currently observed is actually true or if it's a diagnostic bias or selection bias is critical to moving the field forward. We just currently don't have the data yet.
A short comment also related to what was just said. I think there are two things we all can do in research environments. One is to start a biobank. I ask my PhD students to devote 20-30% of their time to developing and collecting the samples, developing the biobank, having full clinical information, having informed consent, all of that. Requires time, effort, and money, but we can do it. Second is prevalence studies, much needed. We actually came very close to this problem with our recent study, now in press, the EndoCost study sponsored by the World Endometriosis Research Foundation, which actually looked prospectively at costs related to endometriosis in, I think, 9 countries, 11 centers. And one of the main problems we had in discussing with the referees about the paper is what is the exact prevalence of endometriosis. And the quality of research is poor, and we need to do better, and we can do better. And I think there, again, the individual responsibility for the researchers here is go and figure out in your own country. Try at least, and that's something we can do.
Along the same lines, but perhaps at a more basic level, is there any anthropologic data, earlier cultures, more primitive cultures, anything about endometriosis in those earlier cultures? Because I'm curious to see if we're not just dealing with the fact that our young women are remaining not pregnant, not reproducing, et cetera, until they get older.
It's a very difficult question, but I've worked for 3 years in Nairobi in Kenya developing the baboon model, and based on that experience in Africa, I was very interested what's the prevalence of endometriosis in Africa. It's underreported, but it's there. If you talk to gynecologists in private practice in Nigeria, in South Africa, in Nairobi, they see it a lot in African patients. It appears that there is a certain lifestyle factor where, of course, infertility in many sub-Saharan populations is related to PID, which with closed tubes may actually be protective against the development of endometriosis, a lifestyle of patients who are seen by private gynecologists with higher education, and a lifestyle which is actually somehow protective against PIDs, that's a population where they see it a lot. On the other hand, also if you look at prevalent studies in other continents like India and Asia in general, it turns out also that, again, limited quality of research, but that the prevalence according to ethnicity, if it's higher in any type of population, it's probably in the Asian population compared to the Caucasian, even higher in the Asian population than in the Caucasian. So I think this is all patches of evidence. The research needs to be done much better. But it turns out, I think in my opinion, based on the knowledge, that it's a global disease affecting all ethnicities and that there is a certain lifestyle component in the sense that if you are at high risk for PID and actually get PID, this is not a population which will get endometriosis later in life.
And I'll just add, Dr. Nazat has a very nice summary of the history of endometriosis that was published last year, and it does show a collection of evidence from hundreds of years ago that may indicate some growing understanding and recognition of endometriosis. But keep in mind that the conflation across time and across cultures in terms of dysmenorrhea, pelvic pain, and the understanding and the implications of when that's considered pathologic and when it is not. And so that becomes a very complex history.
I just want to add something to this, if you don't mind. Christina, I think the word hysteria, historical term, says a lot. Until 20, 30 years ago, we did not see endometriosis evidenced by the way we see today by laparoscopy. The man who's here with us, who had the volumes of gynecological and books in his, and I was very interested those years, 30 years ago, when I bought those books, 8 of them. There was a big chapter on somatogynecological issues on women. We did not know endometriosis as much as we knew today. So from that angle, we're just learning the disease. Out of 15,000 women, 3,000 of them, 20% have severe and moderate dysmenorrhea. That speaks so powerfully and so meaningful. Linda's work, on the other hand, there's so much coming. This big train is coming in research. They're going to illuminate the whole picture. Things will change with the computerized world, the way we speak each other. Things will not get lost in translation. I think we're moving in the right direction. I think it's meaningful to conform this diverse people. It speaks the same language now. We're focusing on different areas, but the same intensity. Patrick's work, small, but so meaningful. And we have to argue decently with the people who don't do excision versus ablation. It changes the data. And I like to, Patrick, particularly comment on that. The study from Boston, where they are doing great work, but when you don't play this thing with the right instrument, the music is different. Patrick, please comment on that. I want you to comment on excision versus ablation issue that you got involved in. Literature also argued this point. Can you comment?
Well, that's a very interesting point. We are actually submitting a pilot study that was a multi-center prospective study that looked at 5 different centers doing excision. These are referral centers in the US. And we're going to try to use this study as a basis and as a sort of a justification to do another randomized controlled trial of excision versus ablation. And I think we try to point out in this study, in this pilot study, that we have to look at perhaps different primary outcomes, that pelvic pain may not be the best outcome to look at because there's many different components of pain. So whereas in the other studies, especially the Healy study, their primary outcome of pelvic pain did not show a difference. Other types of pain did show a difference, and that quality of life may be a more meaningful overall primary outcome to look at in terms of how the symptoms are affecting the woman's daily life. But also there has to be, I think, an issue of quality control, and I think that's going to be, if we do this systematic randomized controlled trial that's multi-center, I think that has to be an element that's involved also. You know, what are these people doing in terms of ablation and excision? What does that actually mean? And we probably need to have a third party involved looking at quality assurance of the techniques we're studying.
Can I actually, I'm actually here because I interact with a lot of engineers in MIT, and one of the projects we've been talking about, and this is sort of with Mark Laufer's inspiration, is being able to do much better job of capturing the images during surgery and doing image analysis and codifying them in a way that would bring information out that could be comparative across, across centers, so that you could, because for us, it's hard. All of these issues that everyone has talked about are very difficult to take, all these different kind of things, and for me to process it and come to and explain it to my colleagues on how we stratify patients. And if we could get more quantitative data starting with the surgery on where the lesions are and what, so if you're doing an ablation study, a question is, you pointed out, you need pathological confirmation of endometriosis, and different surgeons may have slightly different calibrated eyeballs. So could we try to develop tools that would help standardize the way people judge lesions? It may not be possible, but if we start to get databases where we can do the image processing, which is, it's a huge engineering challenge to handle all that data, would that be useful for these kinds of studies that you're?
Well, I think that's really a benefit of laparoscopy, is that it's very easy to make a video, and that would be the basis upon which you could do quality assurance.
We'll take 2 more questions before the break.
Hi, I'm Janesha, one of Dr. Seshkin's very grateful patients. I have 2 questions. Can the onset of this disease be later in life? That's my first question. And the second is, do you recommend preemptive screening for girls who have a family history of endometriosis, even though they don't present symptoms earlier? I'm saying this because thanks to him, again, I have 2 girls, but I need to know how to sort of map out their lives, because I had what I think was severe endometriosis as well. So,
Who would like to answer that?
Is the question really what should be the awareness from parents if they have endometriosis themselves and then they have daughters, what they should tell their daughters? Is that the question?
No. Well, should we screen like earlier in life at age 12, 13, whatever it is, even if they don't have symptoms? Should we be checking them out, or should we just wait for them, to get their painful period to show symptoms before we check them out, given the fact that there is a family history of endometriosis? And also I want to know if this disease can, they could be free of it till 2021, and then it could, the onset would be later at age 25 maybe. Is that a possibility, or is it always, do we think that it's always a disease that sort of presents itself?
Yeah. I think very relevant question, but difficult to answer since there are no data. I think common sense here, in my view, would be not to talk about endometriosis to them until they have symptoms that may be related to endometriosis, like severe pain during the period, and then especially if that's resistant to painkillers or to short course of OCPs. Then I would seriously discuss the issue, and the increased family history, the increased risk if you have endometriosis, that your daughter will also have endometriosis, should then be discussed. But before such time comes, I don't think it's needed. And once there is this resistance during, I think, already 3 to 6 months of OCPs, pain doesn't really become better, then laparoscopy. That would be my suggestion.
Even though it could be a silent,
Well, you see, we don't know about this. We also don't know how many of these girls would actually have a silent course of disease, which then once will turn symptomatic at age 20. We simply don't know. So, and it has to be a balance also between making them worry about something they shouldn't worry about. So it's a balance between, it's risk management. So I think it's a balance between being aware and at the same time not worry them until it's needed.
Our last question is, who has the microphone?
Right here.
I have a very simple clinical question, basically everyday gynecology question. In private practice, we see a lot of young girls. They come in with a lot of dysmenorrhea. How do we counsel them off the bat? I mean, if you tell a mother your daughter might have endometriosis, they never come back. How do we basically counsel this patient with all the interesting information about the diet and lifestyle? Can we counsel them in a way that they are convinced that they can do something before they just disappear again and go to the next gynecologist and get the birth control pill and be forgotten about?
Well, I'll just say with respect to the diet, I mean, the good news so far is, and again, the data do not exist yet showing us the influence potentially of adolescent diet. And this area of research is new in that it really needs to be replicated in more populations. Having said that, the current associations being observed are all consistent with a healthy, what has been shown to be a healthy diet for other outcomes. And so an understanding of the importance of healthy dietary patterns and teaching healthy diet decisions to young children and adolescents is critical across public health. And if there's benefit for endometriosis, that's fantastic. But the good news is that currently the message is consistent with a broader healthy lifestyle approach.
No, you're absolutely right. Let's be straightforward on that. But I was reminded to be sure. You can't be oblivious to her either. Think endo in the back of your mind. Don't forget that. As long as you don't forget that, that's very. Would you tell the patient they may have endo? I would not think so. I don't think we should sensitize young girls without any decent justification. However, make sure you have enough time for that girl and mother. Try to understand. Obviously, the time you spend is very crucial. And you have to find that algorithm of symptoms coming back to you. And if it's powerful there, I think there's a justification to it. If it's really interfering with her. Is there a history in the family, endometriosis, ovarian cancer? I mean, I do ask these questions, whether for some it may not mean much, but I do. So that's very important. What is the issue here? There's a secondary gain or not? Those are issues too. Are there prescription drugs involved, even in young girls? So we have a challenge. Thank you. Good question.
If I could just add to that very quickly, I think there's an opportunity there to really affirm the patient, this young girl, in the fact that her symptoms of pain may not be normal. I think that the overwhelming message that women get, young women in particular, from their doctors is that the pain that they have is normal and don't worry about it, and that's sort of a normal course of being a woman. And that may not be true. And so I think just to have them be affirmed that, you know, if they're missing school, or if this pain is affecting their quality of life, or they're needing heavy doses of pain medication, especially narcotics, that may not be normal, and that may need to be further investigated, and that there are options. And young women, especially these days, they have access to the internet, they can read, but just to offer them the options of how to deal with this pain, which may not be normal, and then they can decide. But I think that's a first step, is to say, this pain that you have, which is affecting your quality of life and your daily activities, may not be normal.
So there is a reason that girl is coming to you at that age. It's very important.
I'm going to be the spoil sport and ask that this session be adjourned. Thank you very much for your attention.